All right, welcome back. I'm here with my friend and colleague, Dr. Scott Giacomucci, and he's going to talk to us about trauma and how it relates to substance use disorder. So with that, I give you Scott.
Thanks, Meryl. Hey, everybody. So my name's Scott Giacomucci. I'm a doctor of clinical social work. And I'm a fellow of the American Academy of Experts in Traumatic Stress and a board certified practitioner of sociometry, psychodrama, and group psychotherapy. So most of my work is at the intersection of addiction and trauma using experiential therapy. So I work in inpatient addictions at Miramont Treatment Center, where I'm the director of trauma services. And then I also have an outpatient practice in Westchester with a new office in media at the Phoenix Center for Experiential Trauma Therapy. So most of what I do with groups is sociometry and psychodrama, and most of what I do in individual sessions is EMDR therapy, which stands for eye movement desensitization and reprocessing. That's a whole nother lecture. We won't get into that one today. So kind of getting into a little bit of the content here. In thinking about the connection between addiction and trauma, one thing that helped me was to look at the statistics and the neurobiology connections. So there's an alarming connection in the research between the number of people with substance use disorder who report histories of trauma. Some experts like Gabor Mate are even suggesting that all addiction is a response to trauma, childhood trauma, usually sexual trauma.
Wow.
In my experience, most of the time there's identifiable trauma. I don't know if I would say all the time, but almost all the time there's unresolved grief and loss, there's attachment trauma, there's neglect, abandonment, or more active traumas. Some of the research shows that 80% of women in treatment for substance use disorder report a history of assault, physical or sexual, and 70% of young people in treatment report a trauma history. So these are self-report numbers, which means that the actual rates are at least a little bit higher,
Right.
Taking into account people's willingness to report these types of events and the potential of repressed traumatic memories. There's also an important research to note called the ACE study, the Adverse Childhood Experiences Study, which really uncovered the connection between adverse childhood experiences and adult mental health issues, specifically addiction and alcoholism, as well as a connection between other medical issues that we normally didn't associate with trauma. The ACE study was a 10 yes or no questionnaire. Before your 18th birthday, did you experience this, this, or this? 3 of the questions were about abuse. 5 of the questions were about family dysfunction, abandonment, neglect. And the 2 other questions were about neglect specifically. So what they found when they correlated these scores was that somebody who reported 4 or more adverse childhood experience types, their chances of becoming an alcoholic as an adult went up 500%.
Wow.
When we look at it in terms of IV drug use, I believe the number was 1,300% increase with 4 or more ACEs.
Wow.
Not only did they find a connection that way, but they found that the higher the ACE score, the higher the percentage was. So somebody who scored 6 or more ACEs had a 4,600% increased chance of using IV drugs as an adult. It's a pretty strong correlation there.
I would say so.
Yeah, there are a lot of other statistics, I don't know off the top of my head, but connections between the number of prescriptions somebody had as an adult, depression, suicide attempts. There was a 20-year less life expectancy. Somebody who had 6 or more ACEs. and maybe even more interestingly and unexpectedly, a connection between medical issues like cancer, lung diseases, diabetes, heart problems, immune system issues, digestive problems were all connected to childhood trauma. So there's a way that chronic and prolonged stress, including post-traumatic stress, impacts the body. One of the best resources about this is Bessel van der Kolk's book, The Body Keeps the Score. When we're working with trauma, when we're working with addiction, we're working with trauma. It can't be otherwise.
Yeah.
So when we're working with trauma or addiction, we have to involve the body in the interventions. I mean, addiction and trauma impact somebody at the biological level, neurobiological level, the nervous system. They impact us at the psychological level, the social level, the spiritual level. Our approaches really have to be holistic approaches that include the body, the mind, relationships, and the spiritual or existential in our approach with clients. In some interesting neuroscience research, they found that when we ask someone to remember a traumatic memory and we take a scan of the brain, the right hemisphere of the brain looks like it's overactive and the left hemisphere looks like it's completely offline. So the language and speech center of the brain, the Broca's area, these are in the left hemisphere, which looks like it's offline when somebody's accessing their trauma. So this really challenges us working with trauma to reconsider how helpful talk therapy is going to be.
Right.
If the trauma is stored in the right hemisphere of the brain and the left hemisphere of the brain is offline, I mean, it makes sense why so many clients don't want to talk about their trauma or don't have words to talk about their trauma. Approaches like psychodrama or music therapy, art therapy, using the creative arts, many people are calling them the treatment of choice when it comes to trauma because of these neuroscience research. Some other interesting research I've come across when they take brain scans of somebody experiencing physical pain and social pain, emotional pain, and they look at the images, they can't tell whose brain is whose. Wow. Physical and social pain look the same in the brain, which validates what every opiate addict already knows, that opiates work great at numbing emotional or social pain. Yeah. So there's a connection here. It makes sense that somebody that's experiencing pain, whether it's from trauma or loss or neglect or whatever it's from, has a desire to numb it, right?
Of course.
If we think about post-traumatic stress disorder, PTSD, almost all of the symptoms relate to the nervous system. All of PTSD symptoms are either about an overactive nervous system, hyperarousal, lack of safety and security, intrusive images and flashbacks, or an underactive nervous system, the numbing, the avoidance, the dissociation, disconnection, depersonalization. So it makes sense that folks that are experiencing PTSD might be attracted to alcohol or benzodiazepines, which are depressants. They numb the nervous system.
Right.
There's a connection here again between PTSD symptomology and the specific drugs of choice even. Another interesting piece with the neuroscience, I could talk about neuroscience all day.
That's great.
One thing they found, I think Dan Siegel, who's the founder of interpersonal neurobiology as a field, he says that the most important finding of the century in neuroscience is that the brain maintains its neuroplasticity throughout the lifespan, meaning that even once we become adults and our brain is formed, experiences still change us, shape us, and structurally change the brain. Previously, people thought that once your brain was formed when you're 23 or 25 or whatever, that it was over. Today we know that that's not true.
Thank goodness.
So experience is what changes the brain, not new insights about ourselves or analyzing ourselves. It's really about new corrective experiences of the power to reshape and renegotiate past experiences that were harmful or traumatic. So with the experiential therapies and the creative arts therapies, because they're more process oriented, they provide new experiences for clients, new opportunities to connect with others in a healthy way, new ways of experiencing themselves in different roles. In psychodrama, on the psychodrama stage, we could even reenact a scene changing somebody's painful experience or changing the way it lives within them, or providing them an experience on the psychodrama stage that would be impossible for them to have in real life, that they've craved for their whole life. But we can use the surplus reality of psychodrama to provide corrective experiences.
Can you briefly describe what psychodrama is for those who may not know?
Yeah, absolutely. Thank you.
Great, thanks.
So, psychodrama comes from the triadic system of Jacob Moreno. So triadic system means it has three parts. First part is sociometry, which is looking at group dynamics, the evolution of groups, the connections of individuals within the groups. Freud talked about psychodynamics. Moreno was looking at sociodynamics. The second part of the triadic system is psychodrama, which is an experiential form of therapy where we externalize, concretize, dramatize the inner experience of a client. So rather than talking about somebody that they lost to an overdose, I would have them choose someone to play the role of their friend that they lost to an overdose and talk directly to their friend and role reverse with the person that they lost. Speak to themselves from that role. Rather than talking about God or a higher power, I could have them choose someone to play the role of God and speak directly to God and switch roles, become God and speak to themselves. Although it's in the US, it seems primarily to be used in psychotherapy. It's also used in education. It's used in training lawyers in trial law colleges. It's used in community work. It's really used in religious communities. It goes beyond psychotherapy as well.
I know that I used that technique, not personally, but when I was being trained in hospice, when I worked for a particular hospice company, part of the training was doing role play and pretending that my coworkers were the hospice patients. And one of the strongest moments of me learning was when my friend and colleague who was playing the role of the patient looked at me and said, "Am I going to die?" And it silenced me. And I was so grateful for that opportunity because they were then able to teach me, what do you say? Which was, yes, you are, and so am I. And I don't know what that is. And so it was a very powerful teaching moment for me as a therapist, and I will never forget that.
Yeah, that does sound pretty powerful. The psychodrama is inherently existential, as you experience firsthand there. It actually emerged from a spiritual and religious practice of Jacob Moreno called the religion of the encounter. He had this vision that he called psychiatry for society, and he wanted to create social change on a larger level using the theater really as the medium. But what you just described is a form of psychodrama that we call role training. And we can do this with clients in recovery from addiction as well. I often use it with my clients to have them practice difficult situations while they're an inpatient in a psychodrama that they're going to run into when they get out of treatment. So person one, you're the role of somebody newly in recovery. and you're practicing setting a boundary. Person two, you are approaching the protagonist as an old friend they used to drink or get high with, and you're trying to seduce them back into the lifestyle. This it's fun, and they really enjoy it. They can have fun. I guess all the music therapists know you can have fun during therapy.
Absolutely.
But it's also helps role train them. It trains them for the role of being a person in recovery. Gives them a chance to practice it on the psychodrama stage, to try out different ways of responding before confronting it in real life.
Right. Right. And I think that's so important in helping to teach people some coping skills, because really, you know, many of the treatment centers that I've worked in have hour after hour of talk therapy groups where there's really nothing happening. They get the same information over and over again. Many of these people have been institutionalized for a long time. They know the rhetoric. They could probably, not that they should, but could run the group themselves. And so it sounds like what you're saying is, let's actually teach them, walk them through the motions, because when they are out in the community, this will happen.
Right.
And all that muscle memory, even of, okay, this is what I do, this is how I talk, sounds really like an important skill for them to learn.
Yeah, exactly, Meryl. I mean, I say that same thing to my clients. You could do the lecture just as well as I could. Most of the clients I'm working with in inpatient have been in multiple treatment centers before, and they probably really could do the lecture just as well as I could.
Sure.
And I like to tie things in with the 12-step lingo. It makes it easier for folks to understand. They say that self-knowledge avails us nothing.
Yeah.
It's about action, not about talking or understanding.
That's right.
And that really fits with the philosophy of all the creative arts therapies, as far as I understand them. That even in terms of development, child development, action precedes the verbal.
Absolutely, it does.
Yeah, we're in action, gesture. Our first language is about gesturing. Usually 2 years before we even develop language and are able to talk.
Right.
So it makes sense that most of our communication as human beings is nonverbal.
Yeah, I see that with my son. He's 16 months old, and he gestures constantly, and he's dancing now, and he's babbling, but he knows exactly what he's saying and trying to communicate, and it's wonderful to watch. And it's also a great lesson, because it is what you're saying, that we are communicating mostly on a nonverbal way. And I know that in my sessions, my group sessions, particularly this group of women who have been chronically homeless, severe trauma, all of them. And when, I might bring in a piece of music and we'll do lyric analysis, which is a very common technique in music therapy. And I notice that what happens is, if we start to talk, nothing's really happening. But it's when we then integrate some sort of music making together as a group, the mood elevates. There's a change that happens amongst everyone. We've gone from, people talking about their depression and their trauma and their grief, to the women standing up and screaming and hollering and dancing and twerking and just having a great time and going, I feel better.
Yeah, that is awesome.
Yes.
Sounds like the groups access their spontaneity and creativity.
They can, most of them.
Yeah. And so actually psychodrama's theory of change is spontaneity creativity theory. So we define spontaneity as an adequate response to a new situation or a new response to an old situation. So in terms of addiction, if we look at the craving as an old reoccurring situation, we want to help a client tap into their spontaneity so that they can respond to cravings in a new way. We want to help them tap into their spontaneity so they can respond to their negative self-talk in a new way. So they can respond to feeling sad in a new way. A lot of what we do in psychodrama and in all the creative arts, I think, is help clients access their spontaneity and creativity.
Mm-hmm. Very much so. So do you have any suggestions for music therapists who are thinking about branching out into working with people with substance use disorder who maybe don't have any experience in this area?
Yeah, absolutely.
Mhm.
The first and probably most important is do your own work. Um, I don't think many of us are attracted to being therapists for the money. I think we all come with our own stuff, and it will impact the work that you do with clients. It can't not.
Yeah.
I mean, the main vehicle of our treatment is through the relationship with the clients. So you yourself is the most important tool that you're using in therapy. So the level of personal work that you've done on yourself definitely shows in the work that you do. It can't not. Um, that would be my biggest suggestion.
Mm.
Um, I'm not sure what music education looks like, but I know for a lot of the other fields like social work, counseling, psychology, um, graduate education is more philosophical based,
Mm.
and it's more of looking at the overview of the field than actually providing practical tools and skills that are useful as a therapist.
Mhm.
So the second thing I could say, I mean, what was second most helpful for me was pursuing postgraduate training. Um, almost everything that I learned, almost everything that I use with clients, I learned in postgraduate training. So do not stop learning. Whatever you do, don't stop learning. Keep on going.
Yeah.
Get good supervision. Don't be afraid to pay for a good supervisor. Pay for quality training. Um, think of it as investing in yourself,
Mm.
investing in your future. Um, I think a lot of people in the field kind of work from intuition, which can be dangerous,
Mhm.
especially with trauma survivors, and
Mhm.
especially if we haven't done our own personal work.
Yeah.
It's so easy to get caught up in the dance of projection and projective identification and transference and possibly harm clients in doing so. So having some sort of clinical theory and conceptualization that guides the choices you're making with clients is so important. Whatever theory you're attracted to, but having a way of conceptualizing and thinking about the client, their behavior, their development, the treatment approach, and having a map that guides your choices makes it safe for the client. With trauma, safety is the most important thing. I mean, we can't do any kind of work until safety's been established. And a lot of the times, providing a safe experience is therapeutic for clients.
Right.
I think in the addictions world, especially, there's a big disconnect between theory and practice.
Mm.
Um, so I'm a big advocate of having a theory, having a conceptualization, having a training, a modality to guide your decision making.
I think that's really great advice and the suggestion because in my experience working in this field, having worked with so many people with such complicated trauma, there have been moments, especially early on, where I'm sitting in the room going, I don't know what to do. I don't know how to handle this situation. I wasn't taught this. I wasn't prepared for this because when I first got into working with people with substance use disorder, I did not know about the trauma piece of it. It
Right.
was only until years later really seeing, wait a minute, I'm not actually working with addiction itself per se. I'm working with grief, trauma, all of these things that have happened to this person that have led them to this, and addiction is just a symptom. It's just a, it's a way for them to deal with
Exactly.
all of these other things. And when I had that realization, I said, I need to go get more training because I don't want to make someone unsafe.
Yeah.
And that happened to me once. And it was one of again, a huge learning moment as a therapist. I had a client say, you led me into the woods. It's like you led me into the woods and left me there all alone. And I'm so grateful he was able to express that to me, because I realized, wow, I'm not making this a safe environment for people. And I'm only here once a week for 1 hour. I can't go this deep with people.
Right. Yeah, your context will really dictate how you do the work that you're doing.
Yeah.
Like my trauma work in inpatient looks very different than my trauma work in outpatient.
That's right. That's right. Yeah. So I think that's a great suggestion. You bringing that up.
Absolutely. Yeah. I mean, I think working the clinical map that I follow, the simplified version of it, it's like any other 3-stage trauma model. We start with safety, strengths, connection, skills building, containment,
Yeah.
resourcing. Only once that's done do we move into the trauma processing.
Yeah.
So I have some clients where I've met with them every week for a year and they come to me for trauma work, but I won't move past the resourcing, safety, containment, and strengths piece until they have enough ego strength, until it's really safe enough to move into the trauma. Otherwise, we're potentially re-traumatizing them, deepening the way the trauma lives within them.
Sure.
It's just not helpful. They need to have a restorative experience before we revisit the trauma. Another piece that is kind of old school addiction treatment mentality, just to label it. A lot of people think that if we make a client cry, that they're healing. That's just not true. Catharsis is sometimes a part of healing, usually a part of healing. It looks different every time. It doesn't always look like loud crying and tears. But if the catharsis is not followed up with a integration, then it was for nothing. There was no change that happened. So I like to think of catharsis of abreaction as a letting go of, an expelling, a releasing of emotion or something, and a catharsis of integration as taking in and replacing, transforming, integrating, growing after the trauma.
Yeah.
So this is the 3 stages of the clinical map that I follow: strength, safety, containment, dealing with the trauma, processing the trauma, and then integration, transformation, post-traumatic growth. Everything that I do, everything from supervision sessions to training sessions to the prompts that I choose in my warm-ups, the roles that come into a psychodrama, everything that I do is guided by this 3-phase structure. The way I do every session moves through those 3 phases, and it keeps it safe.
Yeah, and I think that one of the hardest things, I know, especially being, in private practice and being contracted to come in once a week for an hour in these settings where the group is never the same people. There's never the same people in a group. It can be really challenging to establish what you're talking about, these phases where it's, okay, I'm with the same people for 18 months. When does that ever happen working in addiction, unless these are private clients? So how can I do this within this group, within an hour? Sometimes we have the same clients coming back. Maybe they relapse, maybe they come back into program, maybe they're there longer. But that is one of the challenges I see in that. And I think it's really important to, as much as you can, create that container in the moment for that 50-minute, hour group,
Yeah.
And just the fact of showing up over and over again for people who have been traumatized alone is really creating that container and being a steady person within that facility even
Right.
can be helpful, especially for the people who return.
Yeah. And I work with both types of groups, in inpatient and outpatient. I have some groups that are closed and clients are the same almost every group.
Mm-hmm.
And then I have some groups that I just come in and do a group with whoever's there, hour and 15 minutes, and then I don't see those people again for another group.
Yeah.
In inpatient, the clients are living together. So the way I think of it is leveraging the mutual aid within the group, the relationships that the clients have with each other. That in psychodrama, we say that the healing does not come from the therapist,
That's right.
it comes from the group. And that's a basic 12-step principle as well. So we use sociometry processes or psychodramatic processes to tap into the inherent power of the group to heal itself. A simple way of doing that is breaking the group into dyads or triads. The simplest way of doing it. Break them into dyads or triads, give them a prompt, and you get to step back as a facilitator and just hold space for the whole group. Instead of one person talking at a time at the group as a whole level, you could have 5 different conversations going on at the same time, and group members supporting, educating, and healing each other. So in those types of groups where you're just coming in and leaving, I leverage the group to heal itself rather than expecting myself to provide miracles.
Sure. Sure. I often say, especially the group home where I work, to the women there that, you are each other's best advocates and you're all in this together. This is work that you're going to have to do with each other for your survival, and just really supporting that this is your community here. And I know that the other therapists there do that as well, and which is, like you mentioned, very much in line with 12-step program as well. Tool aid and really helping people recover. It's pretty powerful.
Yeah, it's good stuff.
It is. Well, I just want to thank you so much for taking the time to talk with us this evening, and have a great night, Scott. Thank you.
Thanks, Meryl.
Bye-bye.